All right, so this is the MEC Minute for May 2020. It's actually the first of two MEC Minutes on capnography, and so glad to be doing a MEC Minute on something other than COVID-19. So we're going to do capnography. It's been requested that I do a more detailed review of capnography, so I thought to do an adequate job, we don't have to do it in two sessions. So the first session is this MEC Minute, and if you look at what we have for objectives, we're going to talk about the physiology of respirations, and we're going to review the capnography waveforms. To a large extent, that's mostly going to be this first MEC Minute. And then in the second MEC Minute in June, we'll talk about capnography specific to illnesses and clinical conditions that we would encounter or should expect to encounter in the field. So we're going to get started. This may be a little bit longer than my promised 25 to 30 minute MEC Minutes, just because of the amount of material I think we need to cover to do an adequate job of representing the topic. So, first we have to talk about what's the difference between oxygenation and ventilation. So, we talk about patient being oxygenated, we talk about a patient being ventilated. Well, oxygen is the movement of oxygen from the air we breathe into the red blood cells by way of the lungs. Ventilation is more a mechanical process of moving air in and out of the lungs, and when we do that, we move oxygen in as part of inspiration, and with exhalation we move carbon dioxide out. So they're not quite the same things. Patients can be oxygenated without ventilation, and patients can ventilate and move air through their lungs but still not get enough oxygen. So we can't use these words interchangeably. We just compare and contrast pulse oximetry versus capnography. Pulse oximetry measures the oxygen, and it's a percentage, so the percentage of oxygen carrying capability of the blood. So 100% means that 100% of the capacity of the blood to carry oxygen has been attained. If it's 97, then it's 97% of the capacity has been obtained in terms of carrying blood through or oxygen through the blood. Capnography is a measure of ventilation, and we can use that as a waveform, and it's a measure actually at partial pressure of oxygen, meaning what percentage of the air that is being exhaled is composed of carbon dioxide. So kind of comparing again, oxygenation is measured with pulse oximetry. It's non-invasive. It expresses the percent of oxygen carrying capacity by the red blood cells. So if it's 100%, that means 100% of the capacity of blood to carry blood has been met, to carry oxygen has been met, and so on. And if we have a patient who stops breathing or loses any oxygen supply, it could take up to 5 minutes before we start seeing a change in pulse oximetry. That's because there's a good amount of oxygen in the blood, and it can take time for that oxygen to be utilized as part of metabolism. So if somebody stops breathing, you may not see a significant change in pulse oximetry for 4 to 5 minutes. Sometimes the oxygenation values, the O2 saturation, can be affected by poor perfusion, nail polish, maybe some dysrhythmias, particularly if they're dysrhythmias that are non-perfusing, such as VFib. Or motion artifact. So if you have a patient who's cold, has dusky looking nail beds, you may not get a good pulse ox reading. If you look at the ventilation side, then we're talking about end-tidal CO2 and capnography. CO2 is measured as millimeters of mercury, so it's basically a numeric value, and it's basically, if you look at the total amount of air, the pressure of air is 760 millimeters of mercury at sea level, and 40 millimeters of mercury of that total 760 is carbon dioxide. So if you talk about carbon dioxide and ventilation, and you're using capnography, you can see changes in respiration within seconds. So if a patient acutely becomes apneic, they could go from CO2 that is normal to very abnormal very quickly. In addition, by watching the waveforms, you can measure respiratory rate. So if you have a patient who's breathing normally, then you give them a big dose of narcotic and Versed and interfere with respirations, you can see immediately the change in respirations by watching the waveforms. The waveforms will get longer and they'll have less respirations. Generally, capnography does not have as many problems with dysrhythmias, artifact, and so on. Motion is generally not an issue as long as the sensor is in place in the nose or in line on the endotracheal tube. And if you see a dysrhythmia that's affecting perfusion, you will see a change in the end tidal CO2, but that's because there's a change in perfusion, not because there is a error or problem with monitoring the carbon dioxide output. So how might we utilize capnography? Well, we can use it for immediate information via breath-to-breath monitoring, and we can use that information to make decisions and observations about the airway, about the patient's breathing capabilities and circulation. These are all things that we can assess by utilizing capnography. Capnography also is a good thing to utilize as part of our documentation process, particularly if we have any airway adjuncts in place. For airway, we can use it to verify endotracheal tube placement, and we can use it to continuously monitor endotracheal tube position. I think if we use an endotracheal tube or an iGel or any other type of airway device in the field, we are obligated to monitor the patient with capnography. Because if that tube is in place, you then chemically paralyze the patient or suppress their respirations. You may lose the tube with patient movement or while you're performing other interventions, and capnography will tell you quickly that you've lost the airway and you need to reassess the patient's airway and, if necessary, reestablish it. So it's a great way of monitoring for dislodgement of the endotracheal tube or supraglottic airway. Matter of fact, the MFATS board about 4 or 5 years ago gave notice that effective January 1st, 2021, all patients who have airway adjuncts performed in the field must have capnography in place. They gave a 5-year notice, so the EMS agencies had an opportunity to purchase the devices necessary, either by budgeting appropriately or by obtaining grants. So effective the first of the next year, if you place an endotracheal tube, supraglottic device, you are expected, actually required by the board to have an airway monitoring by way of capnography. So keep that in mind. So capnography, use it for breathing purposes, where we can use it to watch or observe or evaluate for hyperventilation or for hypoventilation. We can also use it as we treat patients for asthma or COPD. We can use it with asthma and COPD to get an indication of severity of illness. We can also use it to determine if the patient has improved during the course of care. So if the patient's capnography, if the patient has COPD and their capnography shows a CO2 of 50, you provide some bronchodilators and maybe some CPAP or BiPAP, and then the CO2 goes down to 38, well, then you can make a pretty safe determination that your treatment and therapy has improved the patient's condition. So that's an example of how we can use capnography to assess response to treatment. And we'll go into more detail about that next month in the second half. Circulation, capnography can also be used to assess circulation. So in a couple of minutes, I'll have a slide. We'll talk about the air exchange in the lungs, but capnography is dependent on adequate airway. You have to be able to get air in and out of the lungs. It's dependent on breathing. You have to have inspiration and expiration to move CO2 past the sensor. And you also have to have perfusion of the lungs by the heart, because if there's no blood perfusing or circulating through the lungs, you're not going to have carbon dioxide delivered to the lungs for exchange in the air and ultimately being exhaled where you can monitor it. So capnography is a great way of assessing circulation. I think all of us now are used to using capnography when we do CPR. Capnography is a great way of assessing the effectiveness of compressions during cardiac arrest. I think Most of you can recall times when you have a patient who's in cardiac arrest. You place either a supraglottic airway or an endotracheal tube. You have a compressor who is starting to get tired. The CO2 may start to go down. You get a new compressor, gets on the chest, and now is able to give better compressions. And you can see that the capnography changes even though there has not been a change in rhythm. So that's a good that's a good use for capnography. Another is to use capnography as a way of assessing for ROSC, or return of spontaneous circulation. I think it's been well shown that when we have ROSC, we will see a change in the end-tidal CO2 before we have an opportunity to do a pulse check. Matter of fact, I don't do pulse checks anymore, and if you look at the 2020 protocol, it says that we don't do pulse checks. We watch for change in capnography, and if there's an increase or a dramatic increase in capnography values, then is the time when we start thinking about ROSC and we start doing pulse checks. So capnography is very good for use in a patient who's in cardiac arrest when we have our airway in place. We can also use capnography to monitor low perfusion states. That's particularly true for patients who may be volume depleted. They just don't have enough circulating volume, so the capnography values may be low, even though they seem to be breathing adequately. So another thing, just as a sidebar caution, we use sodium bicarbonate during cardiac resuscitations. If we give the patient in cardiac arrest a dose of IV sodium bicarb and CPR is continued, you may see a transient increase in the CO2 level, even though there's no ROSC. And that's simply because sodium bicarbonate is metabolized when mixed with acid into carbon dioxide, so it will increase the amount of carbon dioxide in the blood. And even if you have a low flow state, this may be enough of a change to result in a change in the capnography results or capnography values as you're doing compression. So just be careful. If you give the patient a dose of sodium bicarb and all of a sudden capnography improves and goes up, the question is, do they have ROSC, or is it just a manifestation of your bicarb use? So a couple comments about capnography in intubated patients. We use it to verify and document endotracheal tube placement. So if you place an artificial airway, make sure that you obtain a capnography and document the value. You can either put that in the record as under vital signs, or upload the monitor information from your cardiac monitor into your EPCR. Either way, if you place an endotracheal tube, there's an expectation that capnography is started and values are documented. Capnography, again, with intubated patient immediately lets you know if the tube is dislodged. It's also very good for evaluating the effectiveness of chest compressions and return of spontaneous circulation. It's also an indicator of probability of return or indicator probability of successful resuscitation. So if your capnography is less than 20, less than 10, and stays there during your entire 20-30 minute resuscitation, that patient's much less likely to survive the arrest. We can also use capnography in intubated patients as a way of monitoring the patient ventilation in accordance with the patient's needs. An easy example is an intubated patient who has suffered a head injury. Years ago, we thought we had to hyperventilate the patient, blow off CO2 to reduce intracranial pressure. Well, that's actually a double-edged sword, and we found that that's harmful to the patient. I'll talk more about head injuries and cerebral edema next month, but we can use capnography in an intubated patient who's had a head injury or a stroke to make sure we don't ventilate too much or too little. There has to be some discussion about what's the role of capnography with termination of resuscitation. A couple of years ago, we relied on it heavily, and then we realized that as we got better at providing CPR for the patient, we had higher CO2 values, even though the patient was still in cardiac arrest. So we have changed our clinical standard on termination of resuscitation to capnography being something you can consider as part of your decision, but it's not an absolute. So if your capnography has been at 15 for the past 20 minutes and there's been no change and the patient showed no other evidence of return to spontaneous circulation or response to treatment, you can stop. But you should consider capnography as you determine whether or not you're going to continue resuscitation, but there's no longer an absolute value in place. How about for the non-intubated patients? Well, we can use it to assess patients' response to acute respiratory disorders such as asthma and COPD. We can use it to monitor or to screen for sepsis. So in septic patients, capnography less than 25 or CO2 less than 25 is highly suggestive of a serum lactate of 4 or higher. So if you have a patient with whom you have suspected sepsis and you have a low CO2 value, that is highly suggestive of sepsis, and you should follow the sepsis protocol, which includes IV fluid bolus. Patient who's diabetic, we can use capnography for screening for diabetic ketoacidosis. So if you have a patient who's diabetic, not feeling well, and your finger stick blood sugar reads high on the glucometer, you could get some capnography, and if your capnography is less than 28 to 30, high likelihood the patient's in DKA, in which case we'd want to definitely start some IV fluids. We can use capnography in non-intubated patients to assess patients' response to treatments. I already mentioned asthma and COPD, but we can use capnography to indicate that the patient's improved. And then we can use it to help form a diagnosis in the field or an impression in the field of what may be going on with the patient. So let's talk a little bit about hypoventilating non-intubated patients. And if you look at it, capnography can be used to estimate the severity of condition that may be relating to the hypoventilation. So patients who have head injury, stroke, patients who are overdosed on alcohol or drugs, patients who have CHF, or patients who are overly sedated because of medications you may have administered, these patients will hypoventilate and their CO2 values may not be very high. And if you watch the waveform, they have very shallow respirations and they're not moving much air. So this is a great way of evaluating patients. So if you have a stroke patient and they have evidence of hypoventilation on capnography, it may be an indication for intubation in the field in order to secure the patient's airway and adequately ventilate the patient. And then again, we can also use this to assess perfusion status of the patients who may be volume depleted. End-tidal CO2 really reflects changes in ventilation, so we can look at the CO2 values and we get an idea of how well air is moving in and out. We can also get some idea of how well it's diffusing across the membranes in those alveoli and pulmonary circulation. And we can get some idea of perfusion in terms of how well is blood circulating and going to the alveoli for air exchange and carbon dioxide exchange. And we can use that for sepsis, trauma, and any of the other low flow states. Just a quick diagram, and this is basically a diagram where you have the pinkish area, that's supposed to be the artery and vein. You've got the yellowish orange, which is the single alveolus. You have air moving in and out of the alveolus. You have some oxygen in the alveolus as well as carbon dioxide, and oxygen moves from the alveolus into the capillaries and out to the veins, to the heart for circulation, and then carbon dioxide is delivered by the pulmonary artery, and it easily diffuses across generally into the alveolus, which is then where it can be eliminated from the body by expiration, and that's what we measure. So let's just talk a little bit about changes in the end-tidal levels. You can see changes in which case the end-tidal increases if there is decreased cardiac output, but adequate ventilations. So cardiac arrest, you can see, decreased values. You can see there's impaired circulation, so the CO2 level will be lower than you anticipate simply because there's not enough carbon dioxide being delivered to the alveoli. Same thing with pulmonary embolism. So you may see a decrease in CO2 level. And for pulmonary embolism, it's more than just looking for a decreased CO2 level. You have to have a clinical suspicion. The patient may be tachycardic. They may be complaining of pleuritic chest pain. They may have hypoxia when you do their pulse oximetry. So you can see a decrease in CO2 at that point again, because you have portions of the lungs that may be getting air, but they're not getting oxygen or blood supply. I'm sorry, not getting a blood supply because of the pulmonary embolism. And that will result in less carbon dioxide to the lungs, so it's going to have a lower value with expiration. Bronchospasm, you'll see a lower CO2 value simply because the patient's not able to exhale much air and CO2 because of the airway constriction. You can see decreased CO2 because of decreased muscular activity, patients just not metabolizing like they usually can. Similar reason for hypothermia. You'll see a decreased CO2 level because the patient's metabolism is slowing down, so they don't have as much carbon dioxide being delivered to the lungs. And then you can also see a low CO2 level with hyperventilation. So a patient is breathing fast, they're moving more air in and out of the lungs per minute, but they have the same amount of carbon dioxide being delivered to the lungs by the circulation. So each breath will have less carbon dioxide in it simply because the patient's breathing faster. Hopefully I didn't confuse you on that. You can see increases in CO2 with increased cardiac output, so that could include chest compression starting cardiac arrest or patients going back to spontaneous circulation. Patients who are shivering, patients who are having other reasons for increased metabolism, so possibly overactive thyroid, you can have increased CO2 levels because the patient is just having increased metabolism. You can see the CO2 level increase as well because the patient is bronchospastic, and you've treated them and now they're moving air better. During their bronchospasm and during their asthma or COPD flare-up, they may not be eliminating carbon dioxide as well. So once you open up their airways and they start moving air better, you can see an increase in CO2 levels. And then you can also see increases in CO2 levels if the patient's hypoventilating. Kind of like the opposite reason for why you see lower levels with hyperventilation. So if you have the patient hypoventilating, let's say they're only breathing 6 times per minute, but their blood is still delivering the same amount of blood, or I'm sorry, the heart's still delivering the same amount of blood to the lungs, you're still going to have the same amount of carbon dioxide being delivered to the lungs per minute, but with decreased respirations, they will have more CO2 in their breath per ventilation, per breath, just because they have less respirations per minute with the same amount of carbon dioxide being delivered. Talk a little bit about anatomy of a waveform. So this is a typical waveform you see with capnography, and it's basically a measure of end-tidal CO2 or CO2 that's being measured during a period of time. So the x-axis is time, the y-axis is CO2 level, and we consider a normal CO2 to be 40 plus or minus a couple points. So that's what a waveform looks like. So the height of the wave is the amount of carbon dioxide that's being exhaled. The length of the wave is the length of the respiratory cycle. So that's what a waveform looks like. Let's break it down into phases. So the first phase is the green section at the base. That's the baseline. That is as the patient has finished inspiration, so now they're getting ready to expire or exhale. So the baseline at the end of inspiration is phase 1. It's right there where the first upstroke of the expiratory phase begin. And it really, that value represents the carbon dioxide that's in the upper airway or in the anatomical dead space. It's measuring the amount of CO2 that is in the nose and mouth. It's really not telling you what's in the lungs. The second phase is the upstroke, and this is where you're starting to mix the air, the gases of the nose and mouth with the gases coming out of the lungs. And as you exhale, you will see increasing amounts of carbon dioxide. And so this is the up phase. This is phase 2. This is the active exhalation phase. Phase 3 is that steady state. That's the top of the curve, and that's where your CO2 is as you have exhaled or are exhaling. And now what is being measured is all of the carbon dioxide that's in your lungs and is being exhaled. There's no longer any gases from the mouth and nose. It's just what's being measured is what's being exhaled from the lungs. So there's no longer any dead space gas being measured. This is the peak. This is the highest value, and that's the plateau phase. If you look at the end of the plateau phase, that's what we call the end tidal CO2. So that's just before you start inspiring. So that's the end tidal CO2, and that's what we're talking about, that phase of the curve as patients are exhaling when we say, what's the end tidal CO2 value? So when you have a device that's just giving you a CO2 value, it's the end tidal value, and it's at that end of the plateau just before the patient starts inspiring. So we're at that end tidal area, the patient starts to inspire, and now that's phase 4. That's the beginning of inhalation. The patient is breathing in, and what's coming in and what's being monitored is what's coming from the ambient air, and that's where the CO2 drops, and that goes back down to the baseline, so you can start your next respiratory cycle. And this is where basically CO2 has been displaced by oxygen. So let's talk about some series of waveforms. So here's on the top is a waveform where the patient is hyperventilating. So if you measure the period of time, the patient's having more than 12, 14 breaths per minute, and they're breathing faster. And because they're breathing faster, they're eliminating carbon dioxide from their lungs, and the amount of carbon dioxide per breath is less. So this is hyperventilation. It results in what we call hypocapnia, which is the low CO2. You can also see this in low perfusion states too. So in terms of the CO2 level will be low. So low perfusion states can also give you a rhythm or a pattern that looks like this. It's possible that if you have a patient with diabetic ketoacidosis or sepsis, they're in a low perfusion state, plus they're hyperventilating, and you'll see the same graph, same waveform as you're seeing here for pure hyperventilation. The bottom graph is somebody who's hypoventilating. They're breathing more slowly. Their expiratory phase is more prolonged. And if you look at it, their CO2 measures at the plateau over 45. So they're hypoventilating and they are hypercarbic or hypercapnic, meaning they're retaining carbon dioxide. That's why you'll see that higher level. And this is something you may see in a patient who's developing respiratory failure, a patient who has COPD or asthma, a patient who has been given IV narcotics or any other respiratory suppressant. So that question, what would happen to your waveform if you start to breathe fast at 40 beats per minute? What would the waveform look like? How long would the plateau phase be, and how high might it be? So this is another way of looking at hyperventilation. Here we have two for comparison. The top one is normal ventilations. You can see that the patient's got a plateau phase. They have the end tidal point there at the top right corner of each curve. And then if you go down to the second line, that's where patient is hyperventilating. You can see that the plateau phase is shorter. There's also shorter interval in between the peaks, or between the waveforms. But the waveforms are fairly normal in appearance, but the CO2 is below the expected normal of 40 to 45. So the plateau is lower than expected. This is a patient who is hyperventilating and blowing off carbon dioxide. So that waveform indicates the patient is hyperventilating. It could also indicate that they've got, again, decreased pulmonary perfusion because there's an inadequate supply of blood to the lungs, so there's not much carbon dioxide delivered for exhalation. And again, it could also be a consequence of decreased metabolism or hypothermia. Those all things give you a waveform that looks like hyperventilation. For the patient who's hypothermic or has decreased metabolism, you may not see the rapid respirations, but you will see the patient is showing evidence of hypocarbia. How about if you change your respiratory rate, you start slowing your respiratory rate down to 10, what are you going to see? So let's again look at the waveforms. Again, on the top, you see normal respirations, the plateaus between 40 and 45. And at the bottom one, you can see that the patient's having half as many respirations roughly, and their CO2 level is over 45 on the plateau, so the plateau is higher than you would expect. The shape looks fairly normal. It's just a longer plateau, and you have less frequent respirations. So this was what hypoventilation would look like. And hypoventilation indicates you have an increased CO2, that you're not ventilating adequately. A patient may be under the influence of medications or other substances that suppress respirations. Or the patient may be developing or having impending respiratory failure, where you may need to become more aggressive in your airway adjuncts. For today is just a comparison of waveforms. So at the top we have a normal waveform. You have the normal stages. You have the plateau that's around 40 to 45. If you hyperventilate, you're going to see more rapid respiration. So on this page, you see that you, instead of having 3 respirations during the period of time represented, you see 6, and you also see that the plateau is below the normal level of 40 to 45. So that would go along with hyperventilation. The second or the third one down is hypoventilation. The patient's only having 2 breaths per period of time represented here, and the CO2 level is over 45 during the plateau phase. So that patient is hypoventilating and retaining carbon dioxide, just because they're not breathing often enough to get rid of the amount of CO2 they have to. And then the last one at the bottom, you can see a bit of the shark fin. The respiratory rate is a little slower than I would say normal, and I suspect that's because the patient's air trapping and just has to take time to exhale. And you see that shark fin phase, so you don't see the normal fairly flat plateau. So that's kind of my comparison of the waveforms. That's the last slide. So next month we're going to talk some about using capnography for advanced airways, a little more detail than we went into today. And we'll also talk some about specific disease states such as COPD, diabetes, intracranial hypertension, and so on. So if you have any questions, please let me know. Otherwise, thank you for listening, and I'll talk with you next month.